Hey guys, you're watching the Best Practices Show, where we take a look at the best business practices from the best dental practices all over the world. And when you're looking at making the complex simple, it can often be difficult. I've got one of the best restorative dentists on the planet, Dr. Bill Robbins. Tonight, the guy who wrote the book on global diagnosis. Do not miss this. Grab a pen and hit the share button. We'll see you in a second. Hey guys, you're watching the Best Practices Show. Thank you so much for tuning in tonight. And tonight is a crazy special edition. One of my good friends, great teachers, great mentors in dentistry. You don't want to miss this. This guy is awesome. And thank you so much for sharing and giving us suggestions for shows you want to see. We're up now to 16,000 followers, 250,000 views a week, and over 11, or I think it's 11,000, or is it 13,000 following us on iTunes. So thank you so much for watching, tuning in, and adding your comments to the feed. Now, we are shooting this live on Facebook. So if you have questions while I'm talking to Dr. Robbins, add them to the feed and I'll ask the master himself and we'll get the answer straight from the top. And then if you're watching this later on, feel free to add questions to the feed, because again, we want to make sure you get the most out of these in your effort to improve your practice. Now, my guest today, been a good friend of mine for 10 years. It took me forever to get this guy on, and I'm crazy excited. And so I first met you probably 10 years ago, you and your lovely wife, at the Seattle Study Club Symposium. We just grown into great friends. And I really, truly consider you one of the best restorative dentists on the planet. Now, you're an amazing dentist, but you're an amazing human being, just an amazing friend, everything. And you teach me so much. Now, if people don't know who Dr. Bill Robbins is, can you just give us a little bit of your story, buddy?
Yeah, it'd be my pleasure. First of all, let's start off with complete disclosure here. I had to beg my way onto the show. I was way at the bottom of the list, and I finally got myself begged on. So it's a pleasure to be here today with you.
That is a lie. That is totally a lie.
Okay, so I've been practicing dentistry for about 45 years. My dad was a dentist. My grandfather was a dentist. My two uncles were dentists. So I grew up in dentistry. And my initial assumption was that I was going to go back to work with my father in Arkansas, where I grew up. But he gave me a pass. He said, I really think you should think about doing a GPR, general practice residency, before you come back to work with me. And so I did, because you did what your dad told you to do back in those days. And that set me on a journey that never took me back to my dad to practice with him in Arkansas. So I did a 1-year GPR, and then I loved it so much in the VA, I did a 2-year GPR in San Diego with the VA, and then I moved back to San Antonio. And I was in the VA for about 9 years. I was director of the GPR program at the VA. First of all, that was my first academic job. I then joined the Air Force. I lived in Germany for 2.5 years with my wife, and then we moved back to Wilford Hall, Lackland Air Force Base, and I was assistant director of the 2-year AEGD program there. I then went to the dental school in San Antonio, and I taught at the dental school for about 14 years, and I was director of the AEGD program there. And after about 25 years of an academic life, I decided that I wanted to try the other end of the spectrum, which is private practice. So 20 years ago, I left the dental school and went into practice with my good friend and speaking partner, Jeff Rouse. More about Jeff in a few minutes. Jeff and I started practicing together, and we practiced together for a few years, and then we separated. He decided to go back to school and get training as a prosthodontist, and I built a building and went into North San Antonio, and that's where I've been ever since, practicing general dentistry in San Antonio, Texas.
It's a great place to be. Great place to be. And I'll just say this. I'm going to say this maybe a couple times. If you haven't had Dr. Robbins come speak to your study club, he is awesome. Like, just incredible. All of your anecdotes, thinking, the whole process. It's just wonderful, because really what we're going to talk about today is how do we make all this stuff that's crazy complex into something super simple. And you wrote the book on global diagnosis. So take us through, first of all, before we get into the how, why is this so important nowadays, Bill, in this modality of thinking?
Okay, so back in the early 80s, most of us that were trying to do good restorative dentistry dabbled in nathology and all of the complex type of restorative dentistry that was out there for us. And most of us weren't very successful at doing the nathological approach. It was just too precise. And so in the early 80s, two names that everybody's familiar with, John Coys and Frank Spear, got together. They were residents at the University of Washington in the PROS program. And they came up with a concept called facially generated diagnosis. And so back up until that time frame, complex restorative dentistry was treatment planned from condylar position forward. Mm-hmm. And Coys and Spear back then and still teach condylar position is very important. But they came up with the idea that instead of treatment planning these complex patients from condylar position forward, we should be treatment planning from incisal edges back, the way that we have always done with complete dentures. And that was a radical view in the prosthodontic community, fixed prosthodontics back in the early 80s. And at first they didn't find a great deal of support, but when they got out of their program and started teaching it, it made eminently good sense to many of us. I was an early adopter. I heard both of them speak about this early on, and I thought it was brilliant what they were teaching. And so I became a devotee of both of those gentlemen and continue to be that today. Those are the two that have had more impact on me than any other. So back in those days when I was at the dental school, and then about the time when I was transitioning out of the dental school into private practice, I was beginning to lecture out on the circuit a little bit. And my favorite subject that I talked about was the gummy smile. Mm-hmm. And I love talking about the gummy smile and the differential diagnosis for it. First of all, because nobody else was talking about it. And secondly, because it was a subject that general dentists were really interested in. And as I started teaching this differential diagnosis, and once again, I wasn't smart enough to figure it out. I mean, I wasn't the guy that figured it out. It was Coys and Spear and Pat Allen and some other icons in dentistry. But I took their differential diagnosis and I taught it and began to understand it. And it was about this time that Jeff Rouse and I got together. Jeff had been one of my students at the dental school in San Antonio. And after he graduated, we continued to be friends. And ultimately, he invited me into his practice. And that's how I left academics. So Jeff and I started teaching together and learning together. It was a very rich time in our lives, because we were working together. He has a very fertile mind, and we just spent a lot of time talking, learning, and thinking, and going to CE courses also. And he was the one that was clever enough to figure out that the differential diagnosis that I had been teaching for the gummy smile had much greater applicability across the board for a larger group of patients. So we then changed the name from the gummy smile to something like dentofacial diagnosis beyond smile design. And that was our subject title for many years, but it still didn't describe really what I felt like we were trying to teach. So one Friday night on the way back from a study club, sitting on an airplane at 30,000 feet, I came up with the idea of global diagnosis. And so that has become the descriptor of what Jeff and I teach for about the last 15 years. The thing that global diagnosis is about, it's not to take the place of what Coys and Spear gave us and what they continue to teach, which is facially generated diagnosis. That is their idea. They're the ones that created it, and we're the ones that have benefited from it. Their emphasis was traditionally on the incisal edge position in the patient's smile, and that's still incredibly important, figuring out where the incisal edges go. But what I think Jeff and I brought to this whole concept of facially generated diagnosis is an emphasis on the gingiva. And we've come to believe that which defines an interdisciplinary patient is that the gingiva's in the wrong place. And it turns out that there's only 4 diagnoses that are required to tell all of us on Earth why the gingiva, the teeth, and or the landscape surrounding the teeth are in the wrong place. That's the beauty of global diagnosis. It's fairly simple. There are 4 global diagnoses. There are 5 questions that are outlined in our system. And all the dentist has to do is to ask and answer those 5 questions, and that will lead them to the global diagnosis for the patient. Once you name it, then it's much easier to treatment plan it, because it turns out there's only 6 ways we can fix any of these problems. Hence the concept of 4, 5, 6. 4 global diagnoses, 5 questions, 6 tools in our bag of tricks to fix any tooth, gingiva, facial problem. So that's the beauty of our system. It's an overlay, I think, on top of the facially generated diagnosis concept that even makes it more powerful.
Yeah, and it's predictable. So you guys have worked and reworked this entire system. And the cool part is you guys, you're not making this up. I mean, you guys are all over the country watching dentists and listening to dentists try to put all this together. And so you're not only using your learning, but a collected learning to make this happen in 4, 5, and 6. Now, we talked about this before we went on. What your real goal behind this was to create a common language in interdisciplinary dentistry. Just a common language. Can you just talk about that a little bit? Because it's one of those things that I don't think we give enough power to or enough weight to anymore. You hear about concepts of the superdontist, but interdisciplinary dentistry is alive and well today.
Yeah. So once again, that which makes a person interdisciplinary for Jeff and I is that the gingiva is in the wrong place. Right. And that's the beauty of the global diagnosis system. It tells you why the gingiva is in the wrong place. Once you name the problem, there's only a limited number of ways that you can fix any of these diagnoses. And generally, the primary players are going to be the restorative dentist, the periodontist, and the orthodontist. Now, obviously, there's need for all the others. There's need for the endodontist. There's need for the prosthodontist. There's need for the oral maxillofacial surgeon. But the real interdisciplinary team, day in and day out, the periodontist, the orthodontist, and the restorative dentist. And when I first got involved in this 30 years ago, it was primarily the periodontist, because the gingiva was in the wrong place, and there was really only a couple of things you could do to fix it. You could either add tissue or subtract it. You graft it or you cut it away. And so for me initially, interdisciplinary dentistry was primarily about my relationship with the periodontist. But as the years have evolved, the orthodontist has become a major part of my interdisciplinary team. And I would say today, that's probably the most exciting part of the interdisciplinary team. What I found in my teaching at study clubs, most general dentists have a very clear concept of what the periodontist can do for them. They essentially do 3 things. They place implants, they do crown lengthening, or they do grafting. Now, I'm not diminishing what periodontists do. They're my favorites. I love them. I love their talent. But we as general dentists pretty much understand what they provide for us. As a group, general dentists do not understand what the orthodontists can do for them. That's my belief at this point. The orthodontic component to the interdisciplinary treatment planning team is just amazing in their ability to move the teeth in the right place. So I would say those 2 people are the 2 primary people on my team that I deal with day in and day out. And if I'm dealing with these 2 people, then I have to have a common language that we all 3 understand, so that when we're treatment planning these complex patients, we're all working from the same set of guidelines, the same set of diagnoses, the same set of tools. That's the power of having a common language for the general dentist and the other members of the interdisciplinary team.
Okay, can I ask you this question? I love this, and this is what you guys will see in a second why I love this guy. Now, you're a wise man. A wise man takes all of this, and you've learned a lot. How much does self-awareness play in the role? Because we have a lot of young restorative dentists watching this, and they're stressed. And can you just tell us the journey that you've been on, and as you see because I think there are some points where you wake up as a restorative dentist, and you go, look, I used to like endo, I hate it. And then I thought I could do ortho, I can't, right? Like, how much of that plays a role into this of you getting to where you're the best, which is your circle, and doing what you do? And can you just speak to that from your experience?
Yeah, I'd say in some ways, that's a really good question. And in some ways, my journey has been easier than the journey that my younger colleagues are going on, because I took a path that led me through 25 years of academics. And so I had an academic bent, I had an academic understanding, but I didn't have the skills to run an interdisciplinary team or to run a dental office. And so that's what was the big issue for me, developing those skills, with people like you helping to do that, obviously. So my journey came through academics into private practice. And by the time I got into private practice in San Antonio, I was known to the San Antonio community. I'd been lecturing around the United States. And so, I wasn't a national level lecturer by any stretch of the imagination, but I did have a following around the country. At least my name was known to some degree. And so when I started, I had the ability to have patients referred to me based on my reputation, which I'd gotten through the academic realm. Well, most young dentists don't have that. They have to figure out a way to set themselves apart, to make themselves special, all the things that you teach so beautifully. So my journey was, I think, in some ways a little easier. So, it's disingenuous, I think, to talk to young dentists about doing a comprehensive exam on every new patient and doing all the things that lead to this Tier 4 type practice because of the debt that they have and the realities of their lives. And so I think moving towards the type of practice where you're doing interdisciplinary dentistry has to be done incrementally. You have to make a living, and you can't kill the goose that laid the golden egg. And so I think moving, if I'm talking to young general dentists who are in a type of practice that's primarily a PPO practice, an insurance-driven practice, and you want to move to something that's less insurance-driven and more fee-for-service, I think it's got to be done incrementally. And there's two things. First of all, you have to make a mental commitment to do it. So you have to have that goal out on the horizon that you're ultimately going to have a practice that is going to be fee-for-service, and you're going to do the interdisciplinary dentistry. And that's where the incremental part comes. You can't do that in a month, day, year, or 5 years necessarily. I think it's an incremental movement over time. The second thing is that you got to have it on the shelf. If you don't have the skills to provide that higher level dentistry, then it doesn't really matter what your goals are because you can't do it. So I think it's two things. I think it's, first of all, you got to make the decision. That's where you want to go. And then you have to make your future decisions that are incrementally moving your practice in that direction. And the second thing is you've got to spend a lot of effort to get the tools to be able to provide interdisciplinary dentistry. And there are a number of teaching centers around the United States that can provide that for you. And there's clearly a significant cost associated with it. And that's the reason this can't be done overnight. This is a life work, becoming or creating a practice that is a fee-for-service, interdisciplinary type practice. And I think the first step in doing it is realizing that you can't do interdisciplinary dentistry. You can't do comprehensive dentistry if you haven't done a comprehensive exam. So the first thing is that for the young dentists that may be listening, at some point you're going to have to do a comprehensive exam on a patient if you're ever going to be able to present a real comprehensive interdisciplinary treatment plan. Now, I know many of your practices, you can't see 40 new patients a month and do comprehensive exams on them. It's impossible. But you can tell that one that you see in the hygiene room tomorrow that's got all this stuff going on that you can't do it in a 5-minute exam. You have to get the patient back and you have to do a comprehensive exam. So I think the first step in moving from a single tooth practice to an interdisciplinary practice is, at least on the patients that have the potential to be the larger cases, you have to spend the time to do a comprehensive treatment plan, which means gathering all the data that you need to sit down and create, perhaps sometimes with the help of your interdisciplinary team, a real interdisciplinary treatment plan.
Right. I'm so glad you said that too, because it points to the whole idea. You have to be selective on who you're going to do this with, because somebody that has 40 new patients a month can't afford to spend 40 times 2 hours or an hour and a half. So this is really important that you and your team are on the same page, and you're going to be, like you said, picking the ones that have the most opportunity to have this discussion. How long, can I just ask you, how long is a comprehensive exam for you typically?
It's about 30 minutes, but they're in the office longer than that. So my part of the exam is usually about 30 minutes. Usually it takes about 30 more minutes to finish it up.
Okay. Are you doing those any particular time of the day? Because I do get these questions. Do you like them?
I think it's important to see new patients on time.
Right.
So for me, at this stage in my game, I'm very good at running on time. So traditionally, my new patients have either been the first patient in the morning and the first patient in the afternoon, so that I always start on time. But I have to be honest, if you came to my office now, that's not really the case anymore, because I'm not a multi-chair guy. I've got 2 chairs that I move back and forth from, but I don't see but 1 patient at a time. So it's pretty unusual for me to run late. And so I generally, in my office, the new patient experience can be at any time.
Right. Okay. So now, once you've done a comprehensive exam and selected, let's go into, we don't have, we're going to do another show on the 5 and 6, but let's cover the 4 today. So if you're sitting down on a regular basis having a comprehensive exam, what are the 4 directions we can go with the diagnoses?
Well, once again, the thing, if I'm talking to a younger dentist, or really not even a younger dentist, any dentist that has an interest in doing interdisciplinary dentistry, and they ask me, how do I know who that patient is in my practice that I need to do the comprehensive exam on? And one of the other things I haven't mentioned yet that we'll get to at some point today or some other time is that Jeff and I have created a form. It's a simple 1-page form. It's called the core form. And I'm happy to send it to anybody. I'll send it to you by email, and it's a fairly easy form to fill out, and it's powerful. And it only takes 5 minutes. And what it does is it tells the answers to the 5 questions along with many other things. And it tells you why the gingiva is in the wrong place. And once you understand, so here's the answer to the question, how do I know who to do a comprehensive treatment plan on? When the gingiva is in the wrong place. When I look at a patient's face and in their mouth, and the gingiva is in the wrong place, I know this patient defaults to an interdisciplinary patient, because I can't fix them with a burr. Mm-hmm. I'm going to have the help of the orthodontist, the periodontist, the oral maxillofacial surgeon, or a combination of those 3 to fix them. So gingiva's in the wrong place, the patient defaults to an interdisciplinary patient.
Okay. And then immediately, are you guys, can you just speak about how you communicate with those specialists? Because that's a big piece of it too. Not only do you have to have language, but you've got to have a method to be able to communicate clearly back and forth. You're not handing people a slip and sending them to an office, are you?
Right. No, that's for sure. So we do most of our communication, like pretty much everybody's listening to this, by email.
Right.
So that's the primary way that we communicate. What I've come to realize through the years of doing this and trying to be practical about it. I mean, I'm a guy that's making a living. I was doing dentistry all day today. So I make a living doing dentistry like you do. So there has to be some practicality to this. So meeting with specialists is time consuming and sometimes hard to make happen. Right. So here's the time. This is the way I do it. I do most of my communication with the specialist, first of all, by email and telephone. Okay. That's the way we communicate early on. Because I've made a treatment plan. By the time the patient is referred to the specialist, the referral includes my treatment plan. So the specialist knows what the treatment plan is. So that's when we have our discussions by phone and or email. The time that I find most valuable for me to meet with the specialist and the patient is about halfway to 2/3 through the treatment. So let's say this is a 2-year orthodontic perio restorative case. Okay. That's kind of what the standard interdisciplinary patient's going to be. They're going to need 2 years of ortho. They're going to need some perio, maybe some implants, and I'm going to be doing the restorative dentistry at the end. Mm-hmm. What I found is that communicating with the specialist for the first year is pretty easy. Words work fine. Yeah. In other words, I talk to my orthodontist and I say, we've got worn teeth on the upper and the lower anteriors. I want you to intrude the uppers. I want you to intrude the lowers. And we're going to do porcelain restorations on 8 uppers and 6 lowers. Okay. That's how we get the patient started. Okay. The orthodontist can move into the correct direction pretty nicely. But the problem is that the words lose their power the closer we get to the end point. Mm-hmm. So that's when we have to be more involved as a restorative dentist. So one of the things that's changed a lot in the last 5 years in my practice is pre-orthodontic bonding or intermediate bonding. And so almost never in the early days did we do bonding before ortho was done. And very seldom during ortho, we did all of it after the braces came off. That's not the deal anymore. The deal is that if we've got patients with wear and the teeth have to be moved, the orthodontist doesn't have a hint where those teeth go at the end. They can get the gross movements done, but they can't get the fine movements done. So today we've evolved to the position where we do bonding on all of these interdisciplinary orthodontic patients, either before the braces go on or during the orthodontics. It's not uncommon for the teeth to be in positions that don't allow me to do bonding before the orthodontic appliances go on. So it's very common to have the patient in ortho for a year, and at the end of that year, that's the point where I then do my bonding, intermediate bonding, make the teeth ideal, and then the orthodontist finishes the case to the ideal bonding, and then it's much more clear cut. We're not trying to finish to some abstract position in space. We're finishing to anatomically correct teeth.
Right.
So it's halfway to 2/3 through the case where I better get more involved with the specialist, because if I don't, number one, we waste time.
Yeah.
We don't get the implants in a timely manner. We're wasting time at the end of the case. And number two problem is that the teeth don't end up in the right place. They just don't end up where we need them, and then we're doing a compromised treatment at the end. So I'd say the place where I need to communicate with my specialist the most is within the last 6 to 9 months, sometimes a year, halfway into the case. We then do a lot of this communication and bonding and discussion, and then we treatment plan out the final steps so that we're not wasting time during that last 9 months or a year. So that when the braces are ready to come off, we're ready to restore the patient. We don't have to go, oh God, we forgot to put the implant in. So now we got to put the implant in and wait, 3 or 4 more months before we can get in and restore them. I've done all that. I mean, that's been my life in the past, and I don't want to be there anymore. Right. So you cannot do these types of treatments by looking at a patient quickly and hygiene. Mm-hmm. So there has to be appointment time halfway through to look at this patient and really evaluate where you are and decide, am I ready to do my intermediate bonding at this point, or I'm not quite ready to do it? I think it's very dangerous to try to do interdisciplinary dentistry and see the patient maybe once every 6 months in hygiene during those 2 years, because you may be off on a trip during one of those. And so now it's a whole year and you don't have a hint where this patient is. And after, 18 months, you look at them and your eyes get as big as saucers because you can't believe that this is not much has happened in 18 months. In other words, the teeth aren't where they're supposed to be. And it's really your fault because you haven't directed them where to be. Right. So we got to be seeing these patients more than just the occasional drop in, hey, how's the family hygiene appointment? Right. Can't do these kind of patients that way.
Yeah, absolutely. One of the things you've taught me so well in so many ways is this: the more you do up front, the less you have to do later.
Absolutely.
And then the second thing is this: do you agree with the statement? I've heard other people say this. A lot of these dentists could really do amazing dentistry if they just slowed down and took the time to think about this, use a global diagnosis process. Would you agree with that?
I would, but I wouldn't do it in a preachy way.
Right.
I'm not about preaching to other dentists about what they ought to be doing in their practice because I'm not walking in their shoes. I don't have their children in private school, and I don't have sick parents anymore. I've had sick parents, but I don't have any more. So I don't necessarily feel that I'm in a position to be telling everybody that's listening to this broadcast to slow down. Right. Now, deep down in my heart, I believe that slowing down not only makes it better for the patient, but it makes it way better for the dentist. Mm-hmm. So my life is much better when I'm doing things in a controlled manner than when I'm doing things in a more rushed manner. And by the way, I have both of those occurrences in my life today. So it's not like I've always got total control of what's going on in my office and I've got this perfect setup now. That's not the case. So in fact, today I was doing a composite, a single tooth. I do lots of single tooth dentistry in my practice. Probably 75% of what I do is single tooth dentistry, 25% sophisticated dentistry. And I was doing a composite and the contact wasn't good. So I got to take it out and redo it, which put me behind for my next patient. So my life is like your life. but I will say that the more I'm in control, the more fun it is for me. And clearly, the slowing down, the better it is for the patient, for sure.
Yeah, and that's true. That's the truth. That's the truth about a great restorative practice. I heard you say this one year. I love this. You go, a lot of dentists sit on their easy chair on a Sunday and go, I'm looking forward to Monday. And you said, I am not one of them. And can you explain why you say that? Why you say that?
Yeah, once again, I mean, if you are that person that loves to come to the office on Monday morning, I take my hat off to you, but I'm just not that guy. Mondays are really hard for me. Mondays are the time when your favorite dental assistant comes in and tells you she's pregnant, and your least favorite's there, the patient's there at the front door on Monday morning. I mean, Mondays are more difficult for me. And so I don't find Sunday nights to be the most pleasant time of my life because I do think about what's coming up. I don't think about the practice all weekend, but when Sunday night comes, I start to think about it again. So I am not the guy that just can't wait to get to the dental office on Monday morning. Now, Tuesday morning's different. Yeah. I'm raring to go on Tuesday morning. I love doing dentistry on Tuesday, Wednesday, Thursday. I love it. It's just harder for me on Monday.
Right. Well, you don't know what's coming in for the weekend. It's less predictable. By you're kind of in your mode by Tuesday, right?
That's exactly right. I mean, you're back in your game. On Tuesday, you're back on your game. And it's the fun part. You remember it was fun. On Monday, sometimes you forget that this is supposed to be fun. But by Monday afternoon, I'm starting to remember. And Tuesday morning, I'm remembering this is fun. Yeah. I'm lucky to be able to do this. I really am.
Absolutely. And I love this topic. I think one of the hottest topics in the world right now is high quality, simple restorative dentistry, not necessarily the full mouth type stuff. So dig a little bit deeper in this, Bill. What else would you say when you talk about making the complex simple? What are some of the great lessons you've learned that have helped you along the way in making things simple?
Well, for sure, one of the things that has come along that I think has really helped restorative dentists like me is the ability to sequence a case over maybe 5 years. Right. Because today, I mean, everybody that's listening to this is familiar with the concept of putting bonding tabletops on worn teeth and so on. It's not a new concept. People like Bob Margis and other good friends have been teaching this for quite a number of years. But it's here now because we can mill these restorations. They're not very expensive. We can bond them on at an increased vertical dimension. We can get the orthodontic work done so that the teeth are in the right place with these tabletops and with the bonding on the front teeth. And then we can sequence the treatment over the next. You can do a quadrant a year. Mm-hmm. And that's the beauty of being able to do this intermediate type dentistry. It opens up the ability to do a large ticket item for a patient, a full mouth rehab, over 5 years.
Right.
Many of our patients can afford to do a full mouth rehabilitation and pay for it over 5 years. Very few can step up and do it all at once. And that's the reason most of us don't have lots of full mouth rehabs in our practice. Our practice has patients that need them for sure, but they just can't step up and do that in over a 6-month period where they could do it over 5 years. So I think that's one of the most important things that's become available to us, and that is the ability to do this intermediate dentistry, which is really long-term dentistry for many patients, and then to be able to come back and put in more definitive dentistry a quadrant at a time.
Right.
It's a great way to do dentistry.
Yeah, and I always love digging deep in the mind of a great restorative dentist because I love what you said. 75% of it is general dentistry. Like, how many cases are you managing at one time? You don't have full mouths in and out all day long. You probably only have a handful of cases that you're working with at one time, correct?
That's true. And I do almost all of my rehabilitation dentistry and sequenced over time. Okay. And so I'm seldom doing a rehabilitation in less than 6 months. And commonly over more time than that. Therefore, I've got quite a number of patients that are in different stages of the rehabilitation, but I can certainly go a week, 2 weeks, 3 weeks without seeing one of these patients. And so I always have patients that are involved in sophisticated dentistry, but I'm certainly not anywhere seeing near a new one of these every day. And that's not the reality of my practice. Most of my patients, I have a family practice, and most of my patients are in good shape. Mm-hmm. They've been restored, and new patients don't commonly come in needing a full mouth rehabilitation. And so if you have patients that are fairly well restored in your recall system, then you're depending on the new patients that come in. And so, as they come, we do it. But
Mhm.
most of my dentistry is simple bread and butter, single tooth or quadrant dentistry, day in and day out, because that's what my patients need.
Yeah, absolutely. You probably need a good balance of both just to kind of relieve your mind a little bit too. And the thing I like about you is always thinking in terms of systems. So when you talk about global diagnosis, it's a process, it's a checklist. And can you talk about how that is so important in making sure that you have some type of a process in place? Because there's a lot of moving pieces in a dental practice. It's
Yeah.
too hard to think which direction do I go? I mean, it's basically a decision tree that's done every single time around your vision, around which direction we go. That's in the best interest of the patient, correct?
Yeah, for sure. Well, once again, as my vision of interdisciplinary dentistry has crystallized, starting with Coys and Spear and now with our global diagnosis, I can look at a patient and get a sense pretty quickly if this is going to be a single tooth type of patient or an interdisciplinary type patient. I mean, I can make that decision very quickly. If they're in the interdisciplinary side, the way I know they're going to be an interdisciplinary patient doesn't mean they have to accept the treatment plan, but the way I know they're going to be in that direction in my practice is because the gingiva's in the wrong place.
Mm-hmm.
So from a systematic point of view, let's just say for the sake of discussion, I do 75% single tooth dentistry or simple restorative dentistry, and I do 25% sophisticated dentistry. Well, then that means I'm going to be using this global diagnosis concept about 25% of the time in my practice.
Right.
And the way I know that I'm going to need to use it is because the gingiva is in the wrong place. I mean, that's what I keep saying, but that's what it comes back to. The tissue is in the wrong place. So once I have put the patient into the interdisciplinary queue in my practice, then that means I'm going to have the information that I get from this core sheet, and I'm going to have to do the comprehensive exam that includes this interdisciplinary part. So every patient in my practice, I'm lucky, every patient in my practice at this stage in my career gets a comprehensive exam. So every new patient gets a comprehensive exam, but every new patient doesn't get a global diagnosis because they don't need it. Because their teeth and their gingiva is in the right place. You know, all they need is some sealants and some bleach, and they're done. So systematically, it's about looking at the patient's face, lips, teeth, and gingiva and determining, are those all within normal limits or are there aberrations? And if they're aberrations, then you got to have some system to tell you what the aberrations are. And my system is one of those that does it.
Yeah, it's awesome. And you've seen so many things. Like one of the things I'm really curious about is when you look at what you're doing right now and you look at what's on the horizon, what do you expect to see, or what do you think will be different here in the next year, 2 years, 3 years when you talk to dentists out there? I'm just curious.
Oh, I'm clear on what that is for me.
Okay.
I'm at the twilight of my career, let's be honest. And so there's going to be a point at which I'm neither going to want to be at the chair anymore or probably lecturing anymore.
Right.
But I'm certainly not there yet because I'm really getting excited about an area of dentistry and diagnosis that is familiar to many people that are watching this broadcast, and that's digital smile design.
Yeah.
So I've recently, in the last year, become friends with Christian Coachman, and I think we all know that he's a visionary. I mean, he is a really smart man. He's a real visionary in his ability to see what's happening and then see what's happening now and 5 years and 10 years down the road. And as everybody that's listening to this knows, he's developed digital smile design. And so what you do is you capture some images and some study cast and you send it to a lab that can do that design, and you get back a design on the computer that's 2D, but you also get back a design that's 3D. That's the beauty of it now. You get back a study cast that has been printed with the design. So it's a simulation of where you're going to be at the end. And the other thing that I think is brilliant about what Christian is doing is the behavioral side of this. He really talks a lot in the courses he teaches about the motivational side of digital smile design. And so when you get this 3D printed model back of where the proposed case will be at the end, it also comes with a stent that allows you to put a bisacryl product in it, seat it over the patient's teeth, and in 2 minutes you have a mock-up in the patient's mouth to give them a vision of what you can do for them.
Mm-hmm.
And when you give them a vision, it is just amazing sometimes. So I've really, really enjoyed that part. I'm not so technologically great that I just love working with lines on a computer. So I'm glad that you can send all this stuff to Christian and they'll do it for you. What I love is the hands-on part of motivating the patients.
Right.
So the way that digital smile design works is you do the digital smile design first. The second thing is to do the motivational mock-up in the patient's mouth. Then you treatment plan. Because if the tissue's in the wrong place, there's a couple of ways to fix it, at least two primary ways. One is to move it up or down with the periodontist, and the other is to move it up or down with the orthodontist. So in some circumstances, you're going to be doing a combination of those things. That's not really the primary concern of the patient. What they want to know is, what am I going to look like when I'm finished? And the motivational mock-up is so powerful to help with that. So I would say the thing right now that really has my juices flowing is the behavioral aspects of the digital smile design concept that Coachman has given us. So I'm really looking forward to working with Christian and perhaps incorporating our global diagnosis information into his digital smile design, because they go together beautifully.
Yeah.
The digital smile design is primarily about smile design, and the global diagnosis system is primarily about telling the restorative dentist and the periodontist and the orthodontist how to get the teeth in the correct positions to make that vision occur. So they go together beautifully. DSD and global diagnosis, I hope, will become a beautiful marriage. That's my goal.
Oh, we have no doubt. We have no doubt. And then can you speak to the accuracy of this too? Because you've seen this for many, many decades now. I mean, the accuracy has skyrocketed in the efficiency with the digital aspect of things, not only for you, but for also the patient. You can actually predict work, and you can make adjustments on the fly before we even get started. You hear people say this all the time. We want to sell it before we actually do it. And how much of that is true in this case?
Well, once again, it's not so much about selling; it's about the patient buying. It's an emotional decision.
Absolutely.
And when they see the beautiful mock-up in their mouths, I mean, it doesn't really take. Basically, you just have to be quiet. Just don't mess it up. Don't keep talking and mess it up. So the predictability is a giant part of this. I've spent my whole life doing the sophisticated dentistry that I've done has been done based on the global diagnosis first, the case mounted on an articulator, and a diagnostic wax up, many years doing myself. So most of the time through these years, I've done my own diagnostic wax up. I would then prepare the teeth. I would use the matrix from the diagnostic wax up to make the provisionals. I would adjust the provisionals in the mouth until the patient and I were both happy. I would make an impression of the provisionals. That would go to the lab. That's what we call the go-by cast. That's what the lab goes by to make the final restorations. I jump through all those hoops. I then get a case back from the lab that has nothing to do with my diagnostic wax up or my provisionals in the mouth. In other words, they took artistic license and created teeth that had nothing to do with what I'd spent all this time on. Drove me nuts. So it has always been, I think, one of my biggest frustrations to do all of these things leading up to the final restorations, and at the end inserting restorations that look pretty, but they don't look like what my vision was, because the lab technician didn't stick with the spirit of the go-by cast. Well, with digital smile design, that part can be taken away, because with the ability now to mill restorations, we can actually have a design that's been created. From that design, there's a stent. From that stent, we can do the motivational mock-up in the mouth, and it's going to be that exact same design that's going to be used to mill the final restorations. Right. So if there's a little bitty defect in the distal incisal edge of number 7 that the patient loves, that little defect will be there exactly the way it was in the motivational mock-up, because we're no longer depending on the technician to look at the go-by cast and look at the porcelain restorations and try to make them look the same with little matrices and all that they've used forever. Yeah. Now these restorations are going to be milled, and they're going to be milled exactly the same way that the patient okayed the motivational mock-up in the mouth. So I believe the predictability is going to make restorative dentistry much more fun and take away the anxiety. I mean, I've always talked about the day I prep teeth. I love it. I enjoy making provisionals. I love the whole thing. But the day I put the restorations in the mouth, I get sweat rings and still do because of that predictability. I don't really know deep down, although I've gone through all of these hoops, I don't know if the patient is going to love the restorations or not. Yeah. And with this new technique of being able to predictably give what the patient has already okayed, I love that. I love the idea of perhaps not having to face those insertion appointments with sweat rings on both arms.
It's so funny you say that because I've always joked for years, man. There's sometimes I would just want to strap a heart rate monitor around you and then put a blood pressure cuff on you while you're seating some of these cases, because I have no doubt it's spiking like that, and that's exponential stress. And then the other thing, we talk about predictability, which I always think is the number one thing that keeps a restorative dentist happy long term. But think about the hundreds of hours you save on your life by doing it this way, and the stomach lining you keep, by not having to go through these hoops. So we talk about making the complex simple. That's a great way to look at the future, and it's exciting. And for everybody, you've got something to look forward to. I think a lot of dentists too, and no matter what stage of the game, whether you're getting started or you're in a mature stages, you have to have something in front of you that's like a future pull that you're like, that is cool. I'm really excited to roll up my sleeves and embrace the next chapter here.
That's exactly right. And there's probably almost nobody watching this broadcast that's older than I am. So I'm clearly going to be, I'm the oldest guy in the room today, and I am really excited about this new direction for me in restorative dentistry. I don't know if this will be the last really big excitement for me. It may well be, but this is the one that I'm most excited about. And that's the ability to take some of this unpredictability out and to help the patient become motivated early in the process. I love both of those concepts.
Yeah, it's awesome, buddy. Any last words you have for dentists watching this? Because I just love every minute I get with you, and I'm planning on doing a ton of these with you on just different concepts. But what advice would you give dentists watching this today? Let's say I'm a 32-year-old dentist and I'm watching this at midnight and I'm listening to you. What would you say to them?
Well, I would say you spend a lot of time and money getting to where you are, right. And if you're not finding pleasure in it, you got a long, dreary life ahead of you.
Right.
And so I would assume that many of you that are watching this are finding pleasure in it, although you'd want to tweak it in some directions to find more pleasure. I'm assuming that some of you are finding no pleasure at all, because I certainly have colleagues in San Antonio, young colleagues that are working in circumstances that are very unrewarding to them, and they don't want to do it for the rest of their lives. And so I guess my advice would be is to figure out a way to find pleasure in what you're doing. And if you're not finding pleasure in the way you're doing it now, you need to either find a different way to do it, or perhaps, do something else. Don't spend the rest of your life in golden handcuffs, because dentistry is going to give you a reasonably good living, but it's going to kill your spirit.
Right.
So, either find pleasure in what you're doing or change what you're doing incrementally. Don't just throw everything out. Make changes incrementally, like starting to do the comprehensive exam on that patient that it should be done on, and move slowly your practice in that direction. And if those things aren't working for you, make a decision if dentistry was the right decision.
Yeah, buddy, I just love it every minute I get with you. And one of the things I love that you say all the time is the goal in life is to leave the campfire in better condition than we found it. I love that. And that's what you do all the time. So a couple things, if you're watching this. Number one, you've got to get Bill's form on his diagnosis. I have it. It's wonderful. So now this is also on iTunes, Bill. So can you just give us your email address if people are listening to this?
Yeah, if they won't laugh at me.
All right, good. Deal.
If everybody will promise not to laugh at me, it's Robbins, DDS, ROBBINS, DDS at AOL.com.
Only 2 dentists on the planet
Quit
have
saying
that.
it. Quit saying it. It's
You said it's
coming back.
It's not coming back, but I agree with I always love hearing. Now, the other thing, too, is if you haven't had Dr. Robbins speak to your study club, you got to get him out there. So, again, people can just contact you through your email address. That's the best way to get a hold of you.
Yeah, email's the best. Yep.
Yeah. Some study clubs, Seattle study clubs have had you out as many as 4 times in 1 year. You have that much stuff to talk about, and it is fantastic. So
yeah, I love doing study clubs. That's my favorite thing. If I never do another big convention again in my life, I'm totally okay. I'm happy with that. I love doing study clubs because my goal is to change behavior. And it's very difficult to change behavior in large groups, but in smaller groups and study club groups, when you can really get it down in a smaller group of people and you look people in the eye, especially if I have multiple times to come back and sort of hold people accountable, then through the years, certainly, I think, the system has made differences in people's lives for sure.
Amen, brother. Amen, brother. We'll stay on here for a second because we'll say goodnight to everybody else. Now, if you're watching this, do me a favor. If you found this valuable, please hit the share button, share with your friends, because obviously we'd love to have you spread the good word. And then if you have questions for Dr. Robbins, continue to add them to the feed. We'll make sure that he gets back to you and gives you some good, thoughtful responses. And please keep giving us feedback about things you want to see, either just in regular programming or with Dr. Robbins. I'm going to have him back several times, and we can go in any direction for hours and hours and hours. So thank you, Bill. Appreciate you, my friend. So appreciate you guys for watching. So thank you for watching the Best Practices Show. Until we see you next time, keep watching. Have a great evening.
Thanks, Kurt.